All right, welcome to this meeting today here via Zoom. This is the first time doing this meeting, by the way. So, I'm also learning how to navigate through this, but I think, and I hope we can go through this. I think there are a bunch of people, I think. Yeah, I think 2, 4, 6, 8, maybe 20 people around, I think, here. Around. All right. First of all, thank you for joining this meeting. Today I want to talk a little bit about understanding response rates in multiple myeloma. And I think this is a very important topic, that every patient knows how he has to interpret the response in his case. And I think it's a very important topic for all patients to understand this, and that's why I thought to bring this up in this meeting today. First of all, of course, multiple myeloma, some couple of words about that disease. As you know, let me share the screening here. As you know, multiple myeloma is a disease. Can you see that?
Yes.
All right. As you know, multiple myeloma is a type of blood cancer, and it's coming from the bone marrow. And we have got in the bone marrow different cells which are produced, the red blood cells, the white blood cells, and the platelets, and the disease is coming from the white blood cells. And a specific cell is called plasma cells, and these plasma cells are very important for us to form antibodies which are helping us to fight infections. And out of certain reasons we do not know yet, these plasma cells can transform, can become malignant. As you know, any tissue in our body can become malignant, and in this case these plasma cells now become malignant and they transform to myeloma cells. And these myeloma cells are now representing the cancer cells growing in the bone marrow and producing the high amount of these antibodies or the immunoglobulins in the blood and in the urine, which can be seen in the blood or the urine. And of course, this is leading to several problems in the long term. And so, to understand the response in myeloma, it's important to understand this topic. That we know that we have to look at the bone marrow as a very important source where we have to look for the myeloma cells. We have to look at the blood and the urine to look for the antibodies and the myeloma protein, especially also light chains. And this is very important for us to understand the response in multiple myeloma. Of course, the disease is also correlated with bone lesions. As we know, more than 80% of the cancer patients who have myeloma have bone disease, and this is important to understand that as well. They can look like that. For example, lytic lesions, holes in the bones. This can affect all parts of your bones, and this is important to know that also in regards to the response. First of all, we know that the myeloma can lead to kidney damage, especially the protein, the light chains, which are produced by the cancer cells, can go into the kidneys, as the kidneys are our main filter organ. The light chains and the myeloma protein are in the blood, and they go every single second through the kidneys. So the protein goes into the kidneys and they clog up the kidneys, and then they damage the kidneys, and then the patients can even go to hemodialysis and can be dependent on hemodialysis because of the kidney failure. Of course, the symptoms can be very dramatic, in kidney disease, as you can see here. And then, of course, anemia is also one of the major criteria for multiple myeloma. In the bone marrow, we have also got the formation of our blood. And if the cancer cells, especially the myeloma cells, are taking over the bone marrow, the patients are getting anemic because they're occupying the space to produce normal red blood cells, and then the patients are getting anemic, fatigued, tired, and the usual symptoms we see with patients who are anemic can be seen here as well. Another criteria is, of course, what we usually see, or what we frequently see in myeloma patients, is calcium, high calcium levels. The bones are full of calcium. That's where we see the calcium storage. and if the bones are destroyed, the calcium is released into the bloodstream, and the high calcium can lead also to life-threatening conditions. It can lead to nausea, vomiting, constipation, confusion, different problems. Patients have to go even to ICU if the levels are very high. We also see that patients with myeloma have a higher risk for having infections. On the one hand, the antibodies which are produced on a high level are not functioning. That means the patients have not enough antibodies to fight infections. On the other hand, the white blood cells may also drop down, which are important to fight infections, which is also very important finding. Another issue, patients with myeloma have also frequently bleeding and clottings because of the non-functioning platelets, and on the other hand, the immunoglobulins lead to hyperviscosity. That means it makes the blood very thick and viscous, and this may also lead to clottings on the one hand, but also to bleedings on the other hand. So the main goal, what we have to achieve is to get rid of these cancer cells and to achieve a good response. That is the foundation to achieve cure in multiple myeloma. If we achieve a good response, a deep response in multiple myeloma, that is the first step to achieve cure. As you know, multiple myeloma is a disease where cure is very, very difficult to achieve. Usually we can achieve cure in the patients with myeloma here at the Myeloma Center in up to 30% of the cases. We have recently published a paper where we think that cure is possible in a large number of patients, but still the vast majority of the patients remain incurable, and that's why it's important for you as patients to understand the response and the details about that. In order to understand the myeloma, we are doing an extensive workup here at UMS in the Myeloma Center, and as you can see here in the next slide, we are testing, as I said already, the blood, we're testing the urine, we're testing the bone marrow, and sometimes even the focal lesions in the bones or elsewhere, and we're doing extensive imaging studies. And all of this has only one goal: to understand in detail what type of myeloma this is showing. Is it showing a high-risk disease? Is it showing a low-risk disease? And is this a patient where we can achieve cure in the long term? And it is also important that we do this test in a detailed, thorough and precise way, that we really take time to go through this in detail. And that's why we're also running late in the clinic, that we really pay attention on all details of these studies in the blood, in the urine, in the bone marrow, and in the imaging, that we really pay attention to that. I want to quickly go through these in detail. In the blood, we normally do the serum protein electrophoresis and the serum immunofixation. Both tests are very important to detect the myeloma protein in the blood. Both are important to understand that. We also check for the peripheral blood, for the cells in the blood, whether we can detect the myeloma cells in the peripheral blood, for example. Of course, we look for the kidney function, the creatinine, we look for evidence for anemia, we look for the calcium levels, and we also check for other markers like the beta-2M, like the albumin, which are very important findings for the ISS classification, which we usually not use here at UMS. The CRP can be also an indicator for high-risk disease. The LDH are other markers for high-risk disease as well. And of course, we have to look at the specific subtype of the myeloma. IgG, IgA, IgM, IgD, and the light chains, kappa or lambda. I have sometimes patients, sometimes they ask me after several years, what is my myeloma and what is the myeloma protein? It is super important that you know what subtype you have. Is it IgG, is it IgA, and so on, and the light chains, that we really know what type to look for, because our patients come also from far away, out of state, and it's important that they know, that the myeloma markers are coming down, and if it's progressing, that they also know to look at which exact column in the lab results to understand the details of the results. As a next step, you see the urine, right? A lot of people forget the urine, and urine is also very important. You can detect the myeloma protein in the urine as well. As I said, in the blood and the urine, both are important. And in the urine, we do the same test. We look for the urine protein electrophoresis, and we look for the urine immunofixation. And with these tests, we can detect reliably the myeloma protein in the urine. And this is also very important that we check on that anytime when the patient comes to the clinic, that we also check on the urine, especially when he had at the beginning myeloma protein detectable in the urine. As a next step, we have to also, of course, that's the source where the disease comes from, the bone marrow. And in the bone marrow, we look for different tests, and we perform different tests. And as I said, it's all about to understand whether this patient has high-risk disease or low-risk disease. Very simple. And first of all, we look at the morphology. Nowadays we always talk about the genetics and very extensive and very precise testings. This is not necessary. The most important thing is that to look at the cells. We normally ask the pathologist, hey, can you describe the cells? How does these cells look like? How's the morphology? Normally, if you look at the cells in detail, you can describe them. You can approximately get an idea if the myeloma cells look angry and more aggressive, or if they look more benign. And you can really understand that, for example, with the Bartle grade or the immunoblasts, which we see in the bone marrow. Then we also do some other tests. For example, the cIGDNA test, which is a very detailed test, to look for myeloma. I don't want to explain that in detail, but this test also gives us an idea whether there's a more high risk or like a low risk disease related to the maturity of the plasma cells in the bone marrow. And then we come to the FISH test, which is called fluorescence in situ hybridization test. We can look for specific alterations in the bone marrow to look for specific findings indicative of high risk or low risk multiple myeloma. The same with the chromosome analysis in the bone marrow of the cells to look for if there are really bad alterations indicating for high risk disease. And then we have performed in the past our gene expression profiling, which is also a very reliable indicator for a high risk or low risk disease. And we also perform on all our patients what we call the MRD test. I think nowadays every patient should be familiar with that. We do on all our patients the MRD test. MRD stands for minimal residual disease, which is a very detailed test to look for one plasma cell in 1 million cells in the bone marrow. You can really, look for the plasma cells or the myeloma cells in detail in the bone marrow. And this gives you a very good idea whether you still have remaining myeloma cells in the bone marrow on a very low level, yes or no. And we've got two different tests. The one test is run by a flow cytometry, which we do on all our patients, and the other test is called MRD by next generation sequencing, and with the clonoSEQ studies. And this is done also in patients in Little Rock on a regular basis, which has a deeper understanding of the myeloma cells in the bone marrow. And we also do sometimes in patients, I think there is an echo, I think. And we also do on all our patients, or we have done this in the past, the foundation tests, which is a RNA, DNA sequencing to look for also alterations in the bone marrow. We still do that sometimes here to understand further genetic alterations where we can target the myeloma cells in detail. As a final studies, as you have seen, we do the extensive workup in the bone marrow, in the blood and the urine. All are important. And then we do also imaging. We still see a lot of patients here at UMS with referrals from local oncologists who send the patients to us with some basic X-ray studies, and then they come to us, and then we really do this extensive workup, and then we see those lesions which have been not detected by the X-ray. The X-ray is obsolete nowadays in myeloma patients. It should not be done on a regular basis. We should use more dedicated tests such as PET scans, MRI studies. We are using MRI studies on all our patients. We use the MRI DOIPS, the whole body MRI, to look for the whole body, to look for lesions in the bones, which is a very reliable test to look for lesions in general in the body. And then we look also for the MRI dedicated studies, which are called MRI STIR studies. We look at each part of your body, in the skull, in the spine and the pelvis, in the arm bones, in the shoulders, in the sternum, in the clavicle, in the ribs, and to look for bone lesions in detail. And this is also a very important tool to look for bone lesions. And the PET scan gives us not only the anatomic presentation of the lesions, but also the activity behind the lesions. The hotter and the more active the lesions are, the more aggressive these lesions are. And it's important to understand that we really look at the number of the bone lesions, the size of the lesions, the activity of the lesions, which are very important tools. Yeah. As you can see, everything is important, and you have to pay attention, as I said. That makes such a huge difference here at UMS, that we really pay attention, take time to look at the blood, to look at the urine, to look at the bone marrow, to look at the imaging, and to get the whole picture of this patient, whether he has high-risk disease or low-risk disease. And if we have a chance to cure the patient, as I said, in up to 30% we can achieve cure multiple myeloma, and to do these detailed, thorough and precise tests to understand that. I just want to make a small break here, and I just want to ask ask you guys if you have any questions up until so far before I move on to the next step. All right. Let me then go, because this is very important that you understand this foundation, because the next step is going to be that we talk about the response rates in multiple myeloma. And for me it's like that. I always tell my patients, that you must be your own expert on your disease, okay? The doctors are of course the experts, but you must be also understanding the details of your myeloma. What is the response? What is the detail of the myeloma? That you really know by yourself what's going on with you, And as I already said, we have got these 4 things, right? The blood, the urine, the bone marrow, and the imaging. We have to look for the response of the disease. And you can see again in this picture that again the bone marrow, you can see the plasma cells in the bone marrow, and you can see the antibodies or the light chains in the blood and the urine. Yeah, and we look all of that to understand the myeloma. And the first thing is to understand that the best response you can achieve in multiple myeloma is called stringent, defined, complete remission. Yeah, you see that? It's not only complete remission, it says stringent, defined, complete remission. What does this mean? You can see again the blood, the urine, the bone marrow, and the images. Stringent, defined, complete remission means that you have no detection of the myeloma protein in the blood. That means you don't see any protein in the immunofixation and none in the electrophoresis, first. The second is you don't see the myeloma protein in the urine. That means the immunofixation in the urine and also the protein electrophoresis negative. Very important. And then in the bone marrow, you don't see the myeloma cells at all, defined by the MRD test, the minimal residual disease test, which shows it's negative. Okay, that means stringent, defined, complete remission means you don't detect the myeloma protein in the blood, in the urine, and nothing in the bone marrow. Okay, and in the imaging, that's a very important understanding. We have patients with multiple myeloma who come to us after 20 years, and we still sometimes see small lesions in the bones. Sometimes, it's like healing, or it is an old lesion which you have seen in the past and it's still detectable. Normally, it's difficult to say if there are still myeloma cells behind it or not. Normally, you can only identify that by doing a biopsy to stick a needle into that lesion to see that there are no cancer cells. But if a patient lives with that bone disease, let's say, or with that bone lesion for years, very likely, that there's nothing behind it, So the lesions can remain in the MRI or the other studies. And my colleague Dr. Zangari is also doing some studies about healing of destroyed bones. And that means bones can heal by the time. And also in the MRI, as I said, you can detect lesions on a very low level. Normally, by the years, the lesions are getting smaller and smaller and smaller, and then they disappear, which would be optimal, because then you can say, hey, they're resolved and they're gone, which would be great. This is also very frequently we are seeing that. But a lot of patients still have very small lesions, maybe detectable. Of course, it would be great if they disappear completely, but if they remain, we have to observe them, and we have to check on them. That's why even in patients who come, who are in remission or who are in stringent defined complete remission for years, we still do the MRI studies once a year to look at that lesions and to we look at those lesions to understand how these lesions evolve. Okay, so we have talked about that stringent defined complete remission. And then we talk about, as a next step, the complete remission. So what is the difference between complete remission and stringent defined complete remission? Complete remission means that you have detection of the myeloma cells by MRD. Yeah, that means under the microscope, the pathologist may tell you, the plasma cells are gone. They are, normally we say it's less than 5%, as seen here in this table. And as I said, the immunofixation, you don't detect the protein in the blood or the urine, okay? But you may see them in the MRD test. That means the MRD could be, for example, at 0.005% on a very low level. We would still say that this patient is in complete remission, because we do not see anything in the blood or the urine, and the myeloma cells under the microscope are below 5%. So the complete remission means you have no detection of the myeloma in the blood or the urine, but you see them on a very, very low level in the bone marrow defined by the MRD. Yeah? And normally, as indicated in this table, there's a disappearance of the lesions in the bones or the soft tissue or the plasmacytoma if you have one. All right? Is there any question? All right. Then let's move on to the next step. The next step, what we're talking about, is called very good partial remission. Very good partial remission. A lot of patients respond in that way when they get chemotherapy. Okay, again, you have got this picture with the bone marrow, with the plasma cells, and the antibodies or the plasma or the myeloma protein, and now you hit the disease with chemotherapy. Okay, you treat them. We give them extensive chemotherapy, for example, with VDT-PACE, or we do intensive chemotherapy like a transplantation, or we do, for example, a less intensive chemotherapy with 3 different combinations, for example, carfilzomib, Revlimid, dexamethasone, or we give, for example, daratumumab, Revlimid, dexamethasone, and now you see you have a very good partial remission. Yeah, what does this mean? It means that the protein, what you see here, these antibodies, they come down by 90%. Yeah. Let's say the kappa lichens were at 100 and they're now at 10. That means they came down 90% down, and that's what we say. It's a very good partial remission, a 90% reduction of the myeloma protein in the blood. Yeah, and the urine should show less than 200 milligram of protein in the urine. Yeah, that's how it is defined here.
我
But
正好在这里听一个这个课，听一个那个 UMS 的 myeloma 的课。
and I will show this also
如果
here
这
in
个
a.
system 更好的话，那我
I
们以后
will
就
I will show that to you also here in this graph maybe. You know, normally if the patients come to the clinic, you know, we always show you the graph, okay? The graph, you know, that's the most important thing, I think. You know, when you have to always look at the graphs. Yeah. And you can see in this table here, when you have, I have to write this in a different way here. You can see this here maybe. Like this, right? And you have got the protein which is here, and the protein comes down, you get the chemotherapy now, and it comes down like this. But you see that it is not in complete remission. You have still a gap here, you know, to get down to the normal levels. That means it came down 90% down, and this is a very good partial remission. Okay, you detect the.
It's 5:30.
You detect the protein clearly in the blood or the urine, and with the chemotherapy you achieve a very good partial remission by reduction of the protein down to 90%. All right. The next, what we also see, is called partial remission. Yeah, partial remission means you have to only remember one number. Yeah, it's a 50% reduction of the myeloma protein in the blood. Yeah, and in the urine, it is normally that the protein is below 200 milligram in 24 hours. Yeah, so the most important number you have to remember is 50%. Yeah, partial remission means 50% reduction of the protein in the blood. Yeah, and when you look at the lesions, they should also get smaller. For example, the soft tissue lesions or other lesions, 50% down. Yeah, so when you look at this graph, now it should be, the graph should be like this. Yeah, you've got the protein here, and then you hit the myeloma with treatment, and now it comes down like this. Okay, so almost a 50% reduction of the protein in the blood. Yeah, of course, you know, the response is very important. How your myeloma is also reacting. You know, a lot of people ask us, you know, not a good response. Is it bad for me? Is it good for me? It's difficult to say that. You know, at this point, we know, for example, that high-risk patients have usually a great response. That means they have a very aggressive cancer, and they have a very quick and a very deep response, and they achieve the very good partial remission, or they achieve a stringent defined complete remission very quickly. You know, they're very quick achievers. However, the myeloma, as it has come down as fast, it also comes back, you know, as fast as it came down. So the response is very different to estimate in low risk and high risk patients. And it is also important to know that especially in low risk patients, a lot of patients who cannot be cured, again, who cannot be cured, have a very slow response. Yeah, and you know, they have maybe sometimes a very slow response, and it takes them sometimes years to get into remission, in complete remission or in stringent defined complete remission. Sometimes they never even achieve that level. You know, they have always a myeloma protein detectable, and they never go into remission. I always tell my patients, you know, that you and your myeloma have a peaceful coexistence. Yeah, I always tell stuff like that. That means you and your myeloma are living together, and the myeloma, as it is not harming you, it's fine, you know. And this sometimes we also see very frequently, that patients never go to remission, but in certain cases, especially in the low-risk patients, it's also not bad, as long as it behaves very like a very low-risk disease without progression and without harming you. Any questions so far? All right, let's go to the next next slide, and the next what we talk about is called minimal response. Minimal response and stable disease. Both are very important definitions. Minimal response means here you have a 50% reduction. We talked about the partial remission, and now minimal response means it's less than that. Yeah. So the patients have usually only there's a protein, let's say, again, and they have only such a response like this, maybe. Yeah. So it's not a significant response. Yeah, and minimal response is of course not a good finding. Usually the response is between 25% and 49%, very low. You give him chemotherapy, but the myeloma says, I don't want to respond, really. Okay, so of course this is something which is frustrating us, I had a patient recently, some couple of days ago, whom I have given him a very intensive chemotherapy, but the results were not what I've expected, because the cancer is not responding. It was responding very slightly, a very minimal response, and then it's going up again, which is indicative of rather a more aggressive type of disease. Okay. Again, we talked about stringent defined complete remission. That means no myeloma protein detectable in the blood, the urine, or the bone marrow. And the lesions are usually getting smaller in size and disappear by time, or they may be very small and stay there, especially by the MRI studies. Complete remission means there's nothing to see in the blood or the urine, but you may still have a very low amount of myeloma cells detectable in the bone marrow. Very good partial remission. Remember the number 90%. Yeah, the protein, the myeloma protein, comes down by 90%. The next step, partial remission, 50%. Okay, the protein, you get a chemotherapy, you get a treatment, the protein comes down by 50%. Partial remission. Minimal response, less than 50%, maybe 20%, 30%. Yeah. So, and this is something we do not want to have, of course. And the last thing is stable disease. Yeah. Stable disease. I'm going to share my screen again. It does not fit into any category. Stable disease means the protein is here and it behaves like a flat curve, okay? Nothing is happening. Yeah? The stable disease, it's very important in myeloma, I think, because a lot of patients have got their disease. Yeah? That means they're not in remission. I have lots of patients who have stable disease, and the myeloma, behaves like a MGUS or like a small ring disease. I call that always MGUS-like multiple myeloma or small ring-like multiple myeloma. That means the patients got chemotherapy, they were treated with the transplantation, they were treated with extensive treatment and so on, but they never achieved complete remission or stringent defined complete remission. That means we still detect the myeloma in the body, either by protein detectable in the blood or the urine, or by the cancer cells in the bone marrow. But the myeloma is not harming them. Yeah, it's there, it's doing nothing, and it behaves in a stable fashion. Yeah, normally you can detect it on a very low level here. Yeah, normally you see a certain fluctuation of that protein level. Yeah, and you can say it's a stable disease and we can just observe that. You know, I have patients over 5 years, sometimes even over 10 years. The myeloma, although being treated, it's behaving in a very indolent fashion. Indolent means it's not aggressive, it's there, and it's really behaving in a very non-malignant fashion. We can observe the patients without treatment. Yeah. Sometimes we give the patient treatment, and the patient is stable. That means we cannot achieve a complete remission, but the myeloma, we keep that myeloma under control somehow. And then if we stop the treatment, let's say, the patient is progressing again. Okay? Stable disease means the protein, everything stays at the same level, not doing anything, especially very bad if you have bad disease and you get chemo and nothing is happening. Okay, that's of course very bad for those patients. Yeah? But for those who have been treated, low risk patients, stable disease doesn't mean automatically it's bad for the low risk patients, especially for the high risk who get chemo and who are not responding. That's of course not easy. All right. The next I would like to talk about is progression of the disease. Any patient with multiple myeloma should know when he's progressing. You know, and that's why I always tell you guys, you must be your own expert on your disease, okay? I always tell my patients, you have to be aware of your myeloma subtype. What is the myeloma protein? Is it IgG? Is it kappa? Is it lambda? You have to be familiar with this terminology, okay? You have to know these words, and you know, and that's very important, yeah, that you know that. And progression of the disease, of course, is very simple. And you have a protein, and it goes up. Sometimes you have a certain fluctuation, okay? It goes up and it goes down again, and so the most important thing is the trend. The trend is important, that you see that there is an increase. And here in this definition it says that there must be an increase of the M protein up to 25%. And then you can say this is a progression. Also in the urine, for example, it must be above 200 milligram in 24 hours. And the light chains, they say it must be the difference must be above 10 in the light chains, 10 milligram per deciliter. And also in the bone marrow, you can see an increase of the myeloma cells, which should be significantly above that from the previous bone marrow. But you can clearly see the trend. That's why it's important again. Progression, you have to look at the whole picture. You have to look at the blood, the urine, the bone marrow, and the lesions. So you have to get the full picture to understand whether the patient has progression of the disease, yes or not. Sometimes everything looks great. The patient is having no protein in the blood or the urine. He's having no myeloma cells in the bone marrow, but then boom, the MRI shows a new lesion. That means this is a progression, defined here by the table. That means we call this, for example, a macrofocal disease. A lot of local oncologists are not familiar with that. The imaging is so important in multiple myeloma. So many times the myeloma is not growing in the bone marrow, or you cannot detect it in the blood or the urine. You can only see it in the imaging, in the MRI studies, and that's why it's so important to look at those lesions which have been seen at the beginning of the disease. I had a patient, for example, last week in my clinic who had a disease. By definition, he would be in stringent defined complete remission. And he was diagnosed 15 years ago with multiple myeloma. At that time point, this patient had a lesion in his right rib cage. Okay, and then he got the total therapy treatment, what we do normally here in Little Rock, with 2 induction chemotherapies, transplantations, consolidation therapy, maintenance therapy. He was done. MRD negative, he was in remission, and so on. And then the disease came back only as a progression, as a relapse, by the way, as a relapse from that small spot in the rib. And if you don't look for that, you will not see it, simply as it is. Okay? So the imaging is very important, that you look at those lesions, that you understand the progression can be also defined by the imaging, defined by an increase of the size by more than 50%, even more than that, or even earlier than that. And I also would like to highlight the high input of our radiologists. I think Dr. Van Hemert, Dr. Manoj Kumar, and also Dr. Thanendrarajan, who are doing this daily work, who are absolute experts, on this field. These are radiologists who are specialized in detection and interpretation of myeloma lesions, as simple as it is. And this is so difficult sometimes to understand a lesion. Sometimes it is degeneration, sometimes it's inflammation, it sometimes can be also something else, and we have to really understand what is going on in the bones, and we need to have the expertise to understand that, and to understand the increase of the size of the lesions in detail. Yeah. So progression is very important to understand that. Increase of the protein in the blood or the urine at least by 25%, and also most importantly look at the imaging, mainly the MRI, to look for those lesions if they're growing in size, and you get the full picture. Again, the 4 columns of multiple myeloma: blood, urine, bone marrow, and the imaging. You have to get all 4 done before you can make a clear statement about your multiple myeloma.
Hey, Dr. T, this is Blake.
Hey.
I have a quick question for you. First, I just want to say thanks so much. This is incredibly helpful.
Yeah.
But you were just touching on, basically heterogeneity between the bone marrow and bone lesions.
Yep.
So how does that play into a patient's risk for relapse, and the rates of response, and then also how likely they are to progress?
It's like that. You're bringing a very important point. You have lots of patients who are responding very beautifully in the bone marrow, and then you see that those lesions are coming back. And it is like that I personally think, that this is not a good indicator. First of all, I think from the beginning on, a lot of patients ask me, at the beginning we have to do the things right. When we do the initial workup, a lot of doctors forget at the beginning to do the MRI. If you know at the beginning the baseline, that the number of the bony lesions, the size of the lesions, and the activity of those lesions, you already get a good picture of the myeloma. And if the patient had those lesions at the beginning, that means at the time point of the diagnosis, we already know that this is a high-risk disease, and the patient is very likely going to relapse and becoming refractory, and it's very difficult to achieve cure. So the most important thing is to get the baseline done at the beginning. Yeah, and let's say a patient is having at the baseline no lesions at all. He's having only myeloma, let's say, in the bone marrow, and then he's having some protein in the blood and the urine, and no lesions. That's a very good prognostic marker from my perspective. No bone lesions is always better than having lesions. And let's say a patient has, let's say, 5 lesions, and the other one has 50 lesions. That one with 50 lesions has a poor prognosis, period. And also the size plays an important role. Let's say a patient has a lesion which is 10 centimeter in size, and the other one has a lesion which is 1 centimeter in size. That one with a 10 centimeter has a poor prognosis, definitely. And then also the activity plays an important role. We have also published those data in our clinic, in our studies, and the higher the activity in lesions defined by the PET scan, the higher the risk of those patients to become refractory and to become refractory and relapse in the future, although they may achieve a good response at the beginning. And I think nowadays we also learn more about bone disease, and that we have to classify, even with our new Total Therapy 7 protocol, we include patients into these clinical trials just by the PET scan or just by the MRI. That means we have a further understanding of the disease, how we can navigate and and categorize the patients into high-risk disease defined by the imaging purely. And I fully agree with that this again tells us, especially this macrofocal disease, the bone marrow is doing great, but the lesions are growing. This is, from my perspective, has indeed a poor prognosis and is indicating a unfavorable prognosis and difficulty to achieve cure in the long term, indicating a more, indicative for a high-risk disease from my perspective.
So how often do you biopsy the lesions? And when you do biopsy the lesions, how often is the genetic profile differ from the bone marrow?
I think it's a very good question. We have done this and we also do this still. If you have a bone lesion, the most important thing is that to biopsy that. Because we have seen lots of cases, sometimes it can be also something else. Normally our radiologists can really reliably tell us if this is a myeloma-related lesion or not. I mean, they have a very good understanding for that lesion, how it looks like. They can give us a clue. Hey guys, this looks like a myeloma lesion. Especially, the good thing is that we can always go back. I mean, that's the good thing here in the Myeloma Center. You can always go back. We can look at the imaging from 25 years ago, and they can tell us, okay, guys, you know what? The lesion at the T6 was already there 20 years ago. Okay, so now the patient's coming back with the same spot. The patient's having a lesion. So very likely this myeloma, and even though we try to biopsy that, I think it's important to understand the biology and the genetics of that disease. We can normally look at the morphology of the cells to look how aggressive that looks like on the one hand. On the other hand, I think also the genetics are important to look at that fish and also the gene expression profiling to look at that in detail. And we also do sometimes the RNA, the DNA sequencing with the Foundation 1 tests to look for also mutation which you could target. But that's true. We see that very frequently, that in the bone lesions that we see a different genetic profile than in the bone marrow, for example. This may be also indicative that there is a further evolution of that disease, indicating the clonal heterogeneity, and that those lesions are difficult to achieve cure or to get rid of them. But that's true. I mean, that we see these differences in the myeloma, and to also underline that, for example, I had a patient some couple of days ago who had a mixed response. There's something also, it's not listed here, but we see it very frequently, that the patient is getting chemotherapy, and then he's having, let's say, 50 lesions, and then half of the lesions is responding. That means they're shrinking in size, they're getting smaller in size, and it's responding very well. But then, on the other hand, the other lesions are growing in size. Okay, so this again tells us that there is a difference in the genetics and also the biology, how these cells behave to given chemotherapy, and indicating clearly the differences, which again tells us we have to fight this cancer at the beginning. The things must be done at the beginning right. I think that Dr. Barlogi has introduced the total therapy approach several years ago, and a lot of people are now copying us. And Dr. Barlogi already said 30 years ago that we have to give all available treatment for multiple myeloma upfront. That we really try to knock out the disease, the clone, which is early in the bone marrow, which is not highly change. I mean, it's not highly. There's not a high evolution of these myeloma cells. It's important to get rid of the disease early, and there are even clinical trials now going on, which say we have already clinical trials going on with small ring myeloma, high-risk small ring myeloma, who have not the classic Krebs criteria. That we already say, guys, at this level we have to already start to treat the patients, especially those who are very young, let's say in the 40s, 50s, who are going to go to myeloma at a certain time point. So the question is, why are we waiting? Why are we not hitting them right ahead with the intensive chemo to really knock out the disease? So there are thoughts about that as well. I hope that answers your question.
Yes, thanks very much. I appreciate that.
Yeah. All right. I think we talked about the progression of the disease, I think. And the next thing is that we talk about is the relapse. The relapse means I forgot to mention one word, one terminology. You have to understand the word refractory. Refractory is a very important word, And this whole frequently misused and not used in a correct form. Refractory means, and normally refractory and progression of the disease are combined together. I normally put into my notes, the patient has refractory progressive multiple myeloma. What does it mean? Refractory means you get a chemotherapy. Let's say you get daratumumab or Revlimid and Dex, or you get carfilzomib, Revlimid, Dex, and then the patient is not responding anymore to the treatment. Okay, that means the patient is getting refractory to the treatment. That means the patient is not responding anymore. Very simple. Yeah, the M protein was maybe responding for a long time, was coming down, and now suddenly it's a flat curve, and then it suddenly goes up again, although the patient's getting the chemo. Refractory multiple myeloma. And normally I say, if you have refractory, they go up. You can say it is refractory progressive multiple myeloma. And then the next terminology is the word relapse. Relapse means the patient is in complete remission. Okay? The patient comes, let's say as a clinical example, the patient comes for the yearly follow-up visit. Hey, Dr. T, I'm here, I'm coming for the yearly visit. And then boom, the patient has a relapse. That means he was in remission. Yeah? And then the myeloma comes back. It could be after 1 year, after 2 years, after 5 years. I've seen cases after 15 years coming back. Yeah. So the relapse is important to understand that. Relapse means the patient was in remission. Yeah. And you have two different types of relapses. You have a clinical relapse, and you have a relapse from complete remission, or relapse from MRD negativity. And I'm quickly sharing this this screen here, and you see the definition of that. You don't have to understand everything in detail. I'm just, maybe it's better that you don't look at that table. It's maybe confusing a little bit with all these details. Maybe you can just listen to me. It's like that. A relapse from MRD negativity means the patient was MRD negative, okay? And we here say by the flow, it's below the level of 0.001%. Below that level, the patient is in stringent, defined, complete remission. And now, the patient comes after 1 year, we have stopped the chemo, let's say, we have stopped the maintenance therapy, he's coming back, which we frequently see, and suddenly the patient is now back again, MRD positive. Yeah, let's say, for example, 0.005. At that point, you can say, okay, guys, maybe it's not really convincing, let's watch and wait. And then after another 3 months, the patient comes back, and then now the MRD goes up to 0.01%. It goes further up, okay? And you see the patient's having indeed now a relapse. He's relapsing and progressing with the disease, and the MRD is the first evidence that you see a relapse. And that's why we always try to get a bone marrow biopsy and aspiration done, because although it's very painful, the tests for the bone marrow biopsy, but this is the most reliable test to look for the myeloma relapse and to look at that. Of course, we also look at the blood and the urine. You see a relapse from complete remission here on that table, which means you suddenly now see that the M protein is coming back. The M protein was 0, let's say, in the blood or the urine, and now it's at 0.4, or it says less than 0.4, or suddenly, let's say, the immunofixation was always negative. It says the serum immunofixation is negative for M protein. Or normally they say it like that. They say the M protein is not detectable in the serum immunofixation. And now it says in the serum immunofixation, the M protein may be detectable. Or it says appears to be detectable. And then it says finally it is detectable. And that's why it's so important to look at those studies in detail, the immunofixation and also the urine. If the patient has myeloma protein at the beginning in the urine, let's say 5 years ago, if he has a relapse, it can appear again in the urine again. That means you have to look at the urine immunofixation and the urine protein electrophoresis to look for these protein detectable in the urine. Yeah, and this is telling us that the myeloma is coming back in a very early stage. Again, the 4 things I've mentioned, the blood, the urine, the bone marrow, and the imaging, all are important to look for the relapse. Yeah. And the clinical relapse is also mentioned here. For example, if the kidney marks, I had a patient last week where the creatinine jumped up from normal or 2 up to 4, 5. That means, the myeloma protein is causing damage to the kidneys. We look at the hemoglobin. Yeah, is he having suddenly a drop of the hemoglobin levels? For example, if a patient goes from smoldering to multiple myeloma, they have usually a drop of the hemoglobin level, very subtle, but you can detect it. Or the calcium goes suddenly high. You can see this also here, above 11 gram per deciliter. Or the patient's developing suddenly lesions in the bones. And most important, we have to also look for lesions outside of the bones, in soft tissue. We call this extramedullary disease. For example, in the liver or in the skin. It can be somewhere else. You have to always pay attention. In the last 6 years, I've seen patients with myeloma in almost all parts of their body. It can be in the bladder, in the urinary bladder. It can be in the breast. It can be in the soft tissue. It can be almost everywhere. Myeloma can grow anywhere in your body, and we have to always understand that this is that we detect that very early. That we understand that, and now you get also the understanding. Why it is important to look in detail for these tests. Which is very comprehensive here at UMS and very detailed. I think worldwide we are doing the most comprehensive tests for multiple myeloma patients with what we are doing here, and I've explained to you in my presentation. I hope that I could give you some understanding about the response rates in multiple myeloma. It is so important that as a patient you do not only rely on the doctors. Say, yeah, the doctors, they're doing their stuff, and I go there and then it's done. No, don't think like that. You must be your own experts on the disease. Especially, I see patients sometimes coming to me. Yeah, I do not know what the subtype is. What is that IgG? What is the kappa? I don't know what that is. What is the M protein? Or what is that? I don't know. You must know that, okay? I mean, you must be your own expert, and you must know the words you're dealing with, that you are also having that you can really understand your doctors first of all, and that you're also aware what is going on in your body, and this is a very important foundation that you also have in long term a good response, and that you follow up on your myeloma. Yeah, and I also want to say that the relapse I've been talking about right now is important, that we see the patients even after 10 years, once a year at least. Myeloma can even relapse after 10 years or 15 years. We have seen these cases, and that's why it's important to look at that in the long term and to follow up on that. And also with that extensive chemo the patients have received over the last couple of years and sometimes decades, it's important to understand for other diseases, secondary malignancies, other cancers which may evolve over the years. So it's important to understand the whole picture of this disease. Yeah, and I want to summarize maybe at the last that you again have a small overview. Remember that stringent complete remission means no myeloma in the blood or the urine or the bone marrow. Complete remission means no myeloma in the blood or the urine, but you see the myeloma cells on a very low level in the bone marrow. Very good partial remission. Think about 90%. 90% reduction, it's very good partial remission. Partial remission, 50% reduction, it's halfway down. Okay? And minimal response, partial remission, and then comes minimal response means less than 50%. Okay? So they have a very minimal response. And the final thing is stable disease. Stable disease means it's hanging in there. In low-risk patients, it's very good because the myeloma is there on a very low level. It's doing nothing. We can just observe it. In high-risk patients, as long as it's not going up, it's okay. But stable disease, is more or less nothing's happening with the myeloma. And then we have got the refractory progression of the disease. Refractory means the myeloma treatment is not responding anymore. The cancer cells are becoming refractory. And progression means the cancer protein levels are going up in the blood, in the urine, in the bone marrow, or even the lesions can grow in size. And there's also experience to understand that this is not an outlier, that we have a trend going up, that we see that. And then relapse means the patient was in remission. That means, he is in remission for 5 years, and then the myeloma comes back. It can be even earlier than that, after 1 year or 2 years. That you understand that you look at that, and that we look as again I said, to look at the blood, the urine, the bone marrow, and the imaging. I think that is it. I want to finish this here up, and I would like to thank you all for joining that meeting here, and also to listen carefully here what we are talking about. And if you have any questions, I'm open for questions, and let me know, please. All right, I think I thank you for your question, Blake. That was a very nice question you were asking about, and yeah.
Yeah. I just thank you for giving us this opportunity to learn more about myeloma for patients and everyone else here. It's been really helpful.
Yeah.
So just thanks very much for your time.
Yeah, I mean, I thank you guys, and also thank you for joining. And I also would like to appreciate, that we are, of course, on the one hand, we are the doctors who are dealing that, but we're having now, of course, more and more drugs on the market, which are helping us, of course, to fight the cancer. We have more and more drugs coming to the market, and I think this also, I mean, your part is also important, in this venue, that there are more clinical trials to also bring new combinations. To fight this cancer, I think, and to hopefully bring more patients into remission and to cure. And as I said, at this point, we're not able to cure all of the patients. The vast majority still remains incurable, but I think that we are achieving in Little Rock a very good number with cure rates in multiple myeloma patients. And it's always, the biggest thing is when you are in the clinic and you see in a day patients who are 10, 15, 20 years in remission, and that's the thing what we want to see. All right. Okay.
Thank you, Dr. T.
Yeah, awesome. Great, thank you.
Thank you for your time.
And okay, we will catch up then, yeah? And then if there are any questions, you can also email me, or you can also send me something if needed, and you don't want to ask a question right now. All right. Have a good evening, okay? Bye.
Good night.
Bye.
Here.
Bye-bye. Bye. Thank you, please.
Good night.
Bye.
Bye-bye.
Bye-bye. Bye-bye.